Hello and welcome to the Abnormal Psychology voiceover PowerPoint on obsessive compulsive related disorders and trauma related disorders. First, we're going to talk about the obsessive compulsive related disorders. In the DSM-4, they were included with the anxiety disorders. In the DSM-5, there's new chapters for obsessive compulsive and trauma related disorders. It just differentiates them a little more than they did in the past. They still actually come under anxiety disorders. So for the obsessive compulsive related disorders, we're looking at three major ones: obsessive compulsive disorder, OCD, body dysmorphic disorder, and hoarding disorder. And they get a little less part of the population as you go down the list. As we've done in the past, we want to review our definitions. It's called obsessive compulsive disorder. So there must be a difference between an obsession and a compulsion. They go together. The obsession is the thoughts, or are the thoughts. Intrusive, persistent, uncontrollable thoughts or urges. They interfere with our normal activities. We may know they're totally irrational, but it doesn't keep us from having them. And as I demonstrated in the last voiceover, when we talk about thought stoppage, the more you try to stop a thought, the irony is the more it comes back. I use the example always of the white polar bear. Don't think of a white polar bear. Oops, too late. The compulsion is the necessity to either do the mental act or the physical behavior. Could be cleaning, touching, checking. My dad, whenever he would lock a door at his office, he would go back and check it 3 times, push on it, lock, 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 he would always say. And that stemmed from a time when he was a young boy and he forgot to lock the door of the shop, and he got in trouble for it. So whenever he locked that door, he triple checked it. He didn't do it with every door that he did, that he locked, but that one he did. So the compulsion is part of the disorder, and when we get into the addictive disorders, we'll also be talking about compulsions, but the difference between the compulsion for an obsessive compulsive disorder and one of these anxiety disorders is that the compulsion, doing the behavior, doesn't give you pleasure like sex or eating or gambling might. It just relieves some of the anxiety. Does that make sense? It only serves to reduce the anxiety. It doesn't give pleasure. So we've got the obsessions versus the compulsions. You have the thoughts, and they're recurring. They can be totally irrational, and those are the ideas. And then the compulsions are the acts. The obsessions lead to the compulsions. The acts or the compulsion are a result of the obsession. So the obsessions can cause fear, worry, deep anxiety. The compulsion can even cause bodily damage. People that wash their hands a lot, people that need to shower often do it under scalding water because they have to get rid of the germs they fear. So the obsession is thinking about things you want to buy, and you can't get those thoughts out of your mind. The compulsion is going out and buying them, even though you may not have the money to do so. So these are the DSM-5 diagnostic criteria. I'm not going to read those. The thing to remember is the one down at the bottom, that the obsessions or compulsions are time-consuming. They take up at least an hour a day or cause clinically significant distress or impairment. Okay, they keep you from participating in life, much less enjoying life. So I don't know if any of you remember the TV drama Monk. It was used to be advertised as the defective detective. He was a homicide detective that had OCD, and some of the things were quite humorous that he had to go through. But occasionally, you got a real taste of the burden that he carried around for being OCD. So these are some of the high marks or the legend of being obsessive compulsive. Usually starts early in life, before adolescence. Women are more prone to it than men. It can be chronic. And interestingly, across cultures, there are OCD disorders. All cultures have them. Now, if you go online, you're going to find tests. Take the OCD test, and I've included the article that goes along commenting about this test in your threaded discussion for this week. So you can check it out. The link is also in the threaded discussion. Next, we get into the body dysmorphic disorder. And that's where the person is preoccupied, okay? Not just an occasional glance in the mirror or something. They are preoccupied with an imagined or exaggerated defect in their appearance. They consider themselves to be ugly. There's a lot of focus on skin, on hips, breasts, legs for women. Men is height, penis size, body hair, either too much or not enough, muscularity, and the body part can change by culture. But there is a definite imagined or exaggerated defect in the appearance. And people with the body dysmorphic disorder have compulsive behaviors. They're constantly checking their appearance in the mirror. They may tan. They may use makeup. They can quite often become somewhat addicted to plastic surgery. Nothing's ever quite the same. There's pictures of Michael Jackson at 3 different times in his life, and you can see how he changed his appearance over time. Now, I don't know that he was ever diagnosed with body dysmorphic disorder, but he certainly showed some of the symptoms there. Now, what's interesting is there's anxiety with this. There's shame, depression, and usually is tied in with an eating disorder or people that cut themselves or injure themselves. So there's comorbidity, as with most anxiety disorders. So here's the DSM criteria for the body dysmorphic disorder, I'm not going to read it to you, but it's not restricted to weight or fatness. Okay, there's a lot of people concerned about their weight and their fatness, and they're usually pretty actually realistic. But even if it turns into somewhat of an obsession, that's not the same as the body dysmorphic disorder. Now, one of the ones that, again, people are making fun of, so to speak, they've made TV shows about hoarders, and it's really a sad situation. This is not about people that collect a particular thing. They can't give up anything that they collect, and they have this need to save it. You might need it. You could use it. Usually they have so much junk built up over time that even if they did need something, they couldn't find it because they don't catalog it. They just stash it. They get very anxious if they try to discard something, and there's usually a lot of clutter, and it sometimes requires a massive intervention of family just coming in and throwing stuff out. I have a brother that was somewhat of a hoarder, and when I don't think he had the hoarding disorder, but he hoarded a lot of stuff with the idea that, one of these days I might need this. Now, when he sold his home that he had like a large 3-car garage, detached garage in the back that he could never put a car in because he had all this stuff in there. Took him 3 dump trucks to get rid of all the stuff. And that seemed to break him of this. I don't know if he started hoarding again, but he doesn't have room for it now. So as you can see just from this picture, I mean, it can be overwhelming. I mean, the people, they can run out of even room to sit down. The amazing thing is most of the stuff they collect is worthless. Most of them don't recognize that they have a problem or that it's a serious problem. And a third of the people with hoarding disorders hoard animals. I found a picture of this one of dogs below, but it's quite common with cats. People, they just have 100 cats running around. The sad thing about that is they don't take care of the animals. They don't have enough food. They don't have enough water. There's not enough room for them. And of course, the mess that occurs is awful. So all of those 3 things, the OCD, the hoarding, and the body dysmorphic, the lifetime prevalence in the USA is about 2% for OCD, 2% for body dysmorphic, and 1.5 for the hoarding disorder. High comorbidity rates with depression and anxiety, and often substance abuse. Treatments, medications, exposure. We talked about these in the other series on anxiety and the cognitive therapy, cognitive behavioral therapy. And, all of it really needs to go together for it to be successful. Now, let's talk about post-traumatic stress. Again, under the umbrella of anxiety disorders. And this is an extreme response to a severe stressor. As the 2 pictures on the right say, the soldier may leave the valley, but the valley doesn't leave the soldier. The horrors of war, of combat, get stuck in your brain and your memory. If you think back to what you may have learned in cognitive psychology about learning and memory, is if there is emotion attached to the learning, you will remember it much easier. It gets imprinted in your memory that much more dramatically. So all of these are severe emotional situations. Rape for women. There's a lot more women that have experienced rape than soldiers experiencing PTSD, but the face of PTSD is still a soldier. I think that's because it's easier for us to imagine what a soldier goes through than it is for a rape victim. So the trauma leads to intense fears, helplessness. For it to be classified a disorder, the symptoms have to be present more than a month, and usually they are. They can go on for years. They can devastate a person. So what is PTSD? We didn't call it that, post-traumatic stress disorder, until 1980. That was after the Vietnam War, and what they were finding was that these Vietnam vets were having flashbacks. One of the things to keep in mind when we look at the symptoms that bring on PTSD is the concept of hypervigilance. And you can imagine that if you're over in the jungles of Vietnam and your enemy knows the jungle, and they have all these tunnels and can sneak up on you and so forth, that you become hypervigilant. You're constantly on guard, and that just exhausts you. And after a while, it leads to acute stress syndrome, which then eventually leads to post-traumatic stress. Now, it's been around for a long time. Back in the early part of the 20th century, when the railroads were newer, people would get what they call railroad spine. It was a combination of whiplash from the train cars jerking, and also they would carry that over into when the trains had wrecks. They had a lot more wrecks back then, and they would have post-traumatic stress. So in World War I, it was called shell shock. In World War II, they called it battle fatigue, and then finally, now it's called traumatic war neuroses or post-traumatic stress disorder. So there's 4 categories of the symptoms. Re-experiencing the traumatic event or events, an avoidance of the stimuli. So you give the example of you're not going to walk on the street where the rape occurred. Memory loss, negative thoughts and emotions, self-blame, withdrawal. Self-blame goes a lot along with rape. No matter what happens, the woman often feels it's still her fault, and that society has contributed to that. There's the increased arousal and reactivity. People can become so paranoid that they become hypervigilant. This leads to irritability, aggressiveness, self-destructiveness, insomnia, and they're jumpy. An exaggerated startle response. It tends to be chronic, and there's a high risk of suicide and self-injury, and as we'll talk about in a minute, comorbidity, especially with alcohol. So I'm not going to go through the DSM criteria. It's quite lengthy. It's in your text or in the DSM-5 book. You can look at either one. But these are I thought this was an interesting poster, if you will. The 4 top reasons men and women suffer PTSD. The number 1 reason for both is rape. We don't often think about men being raped. Usually men aren't raped, boys are. But it carries on throughout life. Combat exposure, sexual molestation, neglect, childhood neglect, physical attack, physical abuse, being threatened with a weapon. All of these things are the top reasons people suffer from PTSD. Down below are some of the causes: assault, domestic abuse, prison, again, rape, terrorism. So when you think of everybody that's so fearful that we're going to be attacked by terrorists, this has all come about since 9/11. That was 2001, and it just keeps getting built up more and more. First it was Al Qaeda, then now it's ISIS, and these are it's kind of like people are hyper vigilant over something that they have no control over, and that's why they want someone to keep all the Muslims out. Forget the fact that this is America and people of all faiths are welcome. If it's going to lower my anxiety, I'll give up those rights. This is one of the challenges that's going on today with this, because people cannot handle the dissonance involved, the anxiety involved with the trauma or the anticipated trauma. So as I mentioned before, PTSD really became popular as we know it today after the Vietnam War. Interesting stat up there: 4 out of 5 Vietnam vets reported recent symptoms of PTSD 20 to 25 years after the war. Because of the war, and the veterans or the soldiers were self-medicating with heroin, with marijuana. That led to the war on drugs that began in 1971 under President Nixon, and Vietnam was listed as the first war that the United States ever lost. Certainly, we have not won the war on drugs. It's been an utter failure. And I saw a statistic recently that said more people have died from the war on drugs than actually die from drugs. So, but nobody comes up with anything better. Hopefully that will happen now that we're starting to look at addictions as a chronic disorder and disease. But I digress. But you do need to know that 60 to 80% of the vets treated for PTSD also are treated for addiction. I don't have any stats on women and rape and the amount of addiction tied into that, but that would be a good study to find. So the post-traumatic stress syndrome is usually preceded by the acute stress disorder. So symptoms are similar. They're just shorter duration. And most people that suffer acute stress disorder, you get over it in a month, 2 months, and then you're okay. But if you do get diagnosed, if it's bad enough that you get diagnosed with acute stress disorder, there's a much higher risk for PTSD within the next couple of years. Now, I'm going to use this as a little test for myself. Here we are, we're about 14 days after Donald Trump has been elected, has stepped into the presidency, and the nation is rather right now chaotic. Whether you agree with Trump, you voted for him or not, just hear me out. There's a whole lot of stress going on about the way he's doing things. It's really less about what he's doing than how he's doing it. And so, for example, he just signed an executive order banning people from 7 countries coming into the entry into the United States. Okay, that in itself may not be legal, it may not be constitutional, but the thing that's most troublesome is that he didn't check with anybody. He just did it. He just wrote it up. He didn't give the airports and the people on the ground that have to enforce the law any heads up. They were told to do it, and within 30 minutes they had to do it. Some planes were turned around in midair. So this has led to not only the stress of those people, but massive demonstrations of people saying, wait a minute, this is un-American. It's not who we are as a country. And then additionally, the question of whether it's constitutional or legal for him to even do it. So I'm putting this here really for me so that next year when I teach this course, and you can mark it on your calendar, and see where we are a year from now with the amount of post-traumatic stress or acute stress disorders, if those have increased over this past year. Just a thought. So where does the PTSD come from? That 2-factor model of conditioning we talked about, the classical leading to the operant conditioning. You have the same general risk factors that you do with the other anxiety disorders. The things that make it unique are the severity and the type of the trauma. There is some neurobiological link. They're looking at the hippocampus being smaller. There seem to be people with a small hippocampus seem to be more likely to get PTSD. And then again, the avoidance coping, the dissociation, memory suppression, and the other things listed there. So what are the treatments? Medications, exposure treatment, cognitive therapy. If you can treat the ASD, the acute stress disorder, you can prevent the onset of post-traumatic stress coming on later. But essentially, these are the same types of medication, not medication, but therapy that are used in the other anxiety disorders, just with a little different focus. Okay, next, we're going to move into a totally different realm. We're going to start talking about dissociative disorders and somatic symptom disorders. So it's going to get even more interesting as we move along.